Hi, my name is Satish Srinivasan. I'm a consultant corneal surgeon from University Hospital Ayr in Ayr, Scotland. Today, I'll be talking to you about the small aperture optics. As you know, that management of presbyopia is the Achilles heel for any of the refractive surgeons. And there are several options available in the management of presbyopia. We have management at the corneal plane where you could use a laser to create multifocality on the cornea, or you could use a small aperture inlay in the corneal plane, or you could correct presbyopia in the lenticular plane where we could do lens-based surgery and introduce either trifocal intraocular lenses or extended depth of focus intraocular lenses for the correction of presbyopia. In this lecture, I'll be talking to you about correcting presbyopia with a new technology using the small aperture optics principle. So now we are talking about a new technology where we are using yet another tool in the management of presbyopia correction, which is by using a small aperture technology, which once again enhances the depth of focus. This small aperture intraocular lens acts very much in as the principle as SLR camera based on the aperture size. And we all know that bigger the aperture size in the camera, you get a smaller depth of focus. And as we decrease the aperture size, we get a larger depth of focus. So this is the very simple principle which we utilize in the optics of the small aperture intraocular lens. So this is an example of a slide which shows where the depth of focus is set at about 7.96 feet with an f-stop simulating f-stop set at 5.6, which stimulates a human mesopic pupil of 4 millimeter. As you can see from the slide, there are of the different targets, only 2 targets in the middle are legible because the f-stop is set at 5.6 with a mesopic simulating a mesopic pupil of 4 millimeter. But by changing the f-stop to 22, which simulates a pupil size of 1.6 millimeter, you can see from the slide that much more targets come into focus. Once again, these 2 slides drives home the point that by reducing the aperture size, one can increase the depth of focus without compromising on the optical quality of the image. So this is the small aperture intraocular lens, which is called the IC8, manufactured by a company called Acufocus based in California. So it's very similar to a standard monofocal intraocular lens. It's a 3-piece, it's a single-piece acrylic, hydrophobic acrylic intraocular lens with a modified C-loop haptic. It has got a 6 millimeter optic, modified C-loops, and the overall diameter is 12.5 millimeters. The interesting part is in the middle of the optic, where it has got a central mask measuring 3.23 millimeters and a central aperture simulating an artificial pupil measuring 1.36 millimeters. This intraocular lens has got an aspheric anterior surface. It has got 360 degree square edge to reduce posterior capsular opacification, and it has got 0.27 microns of induced negative spherical aberration to counteract for the positive spherical aberration induced by the human cornea. So this is a video illustrating the implantation of the IC8 intraocular lens. The surgical procedure is no different from any other surgical procedure that we used for lens-based surgery, be it cataract surgery or refractive lens exchange. In this, I'm using a Virus, which is a disposable silicone ring, which helps to center the capsular axis on the patient's visual axis based on the first Purkinje image from the operating microscope. So this is a silicone ring which could be placed on the anterior lens surface. This ring measures anywhere between 5.5 to 6 millimeter. In this example, we have used a ring measuring 5.5 millimeters. This nicely centers and helps to center the capsular axis opening over the patient's first Purkinje reflex centering it on the visual axis. Once the capsular access is performed, the standard phacoemulsification is carried out to remove the nuclear lens fragments, and bimanual irrigation aspiration device is used to remove the cortical lens material. This is the injector cartridge for the IC8, and the IC8 is removed from the holding device and placed inside the custom-made cartridge, and OVD is injected into the nozzle of the cartridge to facilitate the smooth transition of the intraocular lens during injection technique. The wound is enlarged to around 3 millimeters, and the IC8 intraocular lens is injected into the capsular bag as one would inject a standard monofocal intraocular lens. Once the IC8 is injected, both the haptics are placed within the capsular bag, and I usually tend to place the haptics in the vertical position where the haptics are placed at 6 and 12 o'clock positions, and then care is taken to remove the residual OVD from behind the intraocular lens so that there is no anterior shift of the IOL. And care is taken to make sure that the IC8 is centered over the first Purkinje reflex. This is the post-operative slit lamp photograph view showing the nicely centered IC8 intraocular lens over the patient's visual axis. I just want to share with you the multi-centered European post-market study with 6 months follow-up data. This was a multi-center European trial which was carried out across 12 sites in Europe. During this 6-month study, 108 subjects were recruited, where IC8 intraocular lens was implanted monocularly in one eye with a refractive target of minus 0.75 diopters, and the fellow eye had a standard aspheric monofocal intraocular lens. This graph shows the mean monocular uncorrected visual acuities in the IC8 eye for far, intermediate, and near at 1, 3, and 6 months. The blue line depicts the uncorrected distance visual acuities in logmar. The orange orange line depicts the uncorrected intermediate visual acuities in logmar, and the green line depicts the uncorrected near visual acuity in logmar at month 1, month 3, and month 6. And as you can see, these patients achieved excellent uncorrected distance, uncorrected intermediate, and uncorrected near visual acuities in the IC8 eye at month 1, month 3, and month 6. This graph shows the mean binocular uncorrected visual acuities once again at far, intermediate, and near at month 1, month 3, and month 6. And as you can see from this graph, because of the binocular summation, the binocular uncorrected visual acuities for all distances are better compared to the monocular acuities in the IC8 eye. This is the binocular target corrected defocus curves where the IC8 eye has been targeted for minus 0.75 diopters of myopia. And in this graph, the defocus curve shows that patients were able to achieve continuous functional range of vision right from metropia to over 2.75 diopters. This is the contrast sensitivity data at 6 months where binocular contrast sensitivity was tested, and this is equivalent to the contrast sensitivity in the monofocal eye, and neuroadaptation and retinal response to illumination will further boost the contrast performance in the IC8 eye. Even though monocularly the IC8 eye has slightly reduced contrast compared to the monofocal eye, the binocular contrast sensitivity shows no difference when compared to the monofocal IOL implanted eye. This is the influence of the refractive error on visual acuity, showing that the IC8 IOL eye can tolerate up to 1 diopters of deviation from the refractive target without compromising on the uncorrected distance, uncorrected intermediate, and uncorrected near vision eye. And this is the study which was published by Robert Ang from Philippines in clinical ophthalmology, showing that the small aperture intraocular lens can tolerate up to 1.5 diopters of pre-existing corneal astigmatism. So in other words, these patients do not require a toric intraocular lens if they have a pre-existing corneal astigmatism of 1.5 diopter, up to 1.5 diopters. This could be corrected by just using a IC8 intraocular lens, where this pinhole technology can correct this pre-existing corneal astigmatism. So in summary, I think from our clinical experience, it's very clear that the small aperture lens can provide good uncorrected distance, uncorrected near, and uncorrected intermediate vision monocularly in the implanted eye, targeting for myopia from either from 0.75 diopters up to 1 diopter of myopia in the IC8 eye, gives them enhanced near vision without compromising on the uncorrected distance vision. Because of the small aperture technology, patients don't have any dysphotopsia symptoms, and they seem to have a very good tolerance and seems to be very high patient satisfaction. Thank you for your attention.